important launch of our consensus study, whose name is very long name though, Achieving Good Governance and Management in the South African Health Systems. So this report has started in 2020, which has been a very long time. I think often we were criticized, why has the report not been published? But here you are. I cannot think of a more and most opportune time for the launch of this particular report. So good morning, my name is Susan Veldspan. I'm the Director of the Scholarly Publishing Program at the Academy of Sciences of South Africa. Welcome once again. A particular welcome to our panel members who are all sitting here in front. It's great to see you. We started in COVID and we met online all the time. So it's a real privilege for me then this morning to stand here and actually to physically meet them, considering the couple of tough years that we all went through the past years. So I'm absolutely delighted then to welcome you all once again. And please can I just start and just give you a little bit of background about our consensus studies. Consensus studies or evidence-based studies is a very particular and a very specific process which the academies actually embark on. So we recognize that the societal mandate to contribute evidence-based solutions to national and global priority challenges, of which the national health system, of course, is, I think, at the moment, one of the major challenges. Lots of discussion, lot of consultation, etc., those for and those against. So I think and I hope that this consensus study will actually give perspective on where are we going and how are we going forward with this whole report. Our processes are very rigorous because we try and strive for science to policy advice to government, to support the decision making in the formulation and implementation of the policies. So that's why I said it's very, very important. So we started in 2020, as I said, in September, and we had a voluntary 7-member consensus study panel, and this is very important. All the work and the panel members, their work is voluntary. And we really salute you amidst your very busy schedules that you actually embarked on this particular process. So thank you for that. There were expert practitioners from various disciplines within South Africa public health and health systems to comprehensively actually examine all the pillars which support achieving good governance and management in the South African health system, the health system that's so important for all South Africans, the access to health care, and being as a human right, I think, puts so much emphasis on the importance of the actual publishing of this report and launching it this morning. So this report then encapsulates the culmination of the panel's work, very hard work, lots of discussions, lots of meetings, etc., offering a detailed study of the governance challenges within the South African health system, underscoring the multifaceted nature of government's deficiencies and their profound implications, as well as highlighting the possibilities for positive action. And I think that's very important. That's always the aim of our consensus studies, is to make a positive contribution to the system and to policymakers and the implementation thereof. The recommendations in this report address the key governance elements of strategic vision and policy design, participation and consensus, accountability, transparency and protection against corruption. Commitment to the recommendations will strengthen the governance and leadership of the current health system and move us closer forward in achieving universal health coverage. It gives me great pleasure also then to welcome our, she says it's a very long title, the Interim Vice President of the Academy of South Africa, Professor Eagle Gledhill. Eagle, thank you very much always for your support. At these occasions, it really is very encouraging to see that our council is so involved in that what we do and also acts upon responsibility in terms of the launching of our things. So Professor Gledhill is a visiting adjunct professor in flow physics at the University of the Witwatersrand. She specialized in transonic computational fluid dynamics, typical of physicists. Not that I know what it means, I must add. She was also with the CSIR. She was the past president of the South African Institute of Physics and the past chair of the International Union of Pure and Applied Physics Working Group on Women. And she serves on the World Cultural Council Interdisciplinary Committee. As said, Professor Gledhill is also a member of ASSAf, the interim vice president of the ASSAf Council, and we're very proud also to say that she is the vice chair of our Committee on Scholarly Publications at ASSAf. So you can see Eagle is very entrenched in the work of ASSAf, and we are grateful for your presence this morning, Eagle. So please, would you come and just address the meeting? Thank you very much.
Susan. Thank you very much indeed. Good morning, distinguished guests, colleagues and friends. It's a privilege to welcome you all to this particular launch. I can't help remembering Minister Derek Hanekom saying when he went to the launch of the first telescope of the square kilometre array, he thought a launch was something where a large piece of metal took off into the sky, and he was relieved to find that he would not be standing next to it during that. But thank you. We are launching the consensus study report on achieving good governance and management in the South African health system. So I'm honoured to share in the culmination of the diligent efforts by our amazing panel of experts who have volunteered their time and expertise over the past 3 years. I'd especially like to welcome our speakers today, Professor Lekan Ayo-Yusuf, Professor Lillian Dudley, Mr. Anelo Yawa, Dr. Mvuyisi Mzukua, Professor Salome Maswime, and Dr. Jürgen Pillay, as well as, of course, Mrs. Susan Feltzman, who will be wrapping up at the end. ASSAf holds a societal mandate to contribute evidence-based solutions and advice that reach from science to policy. The role of evidence in decision-making, whether it's government or civil, is not only through policies and implementation, but in providing traceable facts to authorities on the reality of the situation. This report is a testament to our commitment in that. I think you have heard of the 7-member panel. Their charge was to examine the pillars supporting governance and management within the South African health system. They've done this comprehensively. This report encapsulates their extensive analysis and offers a detailed study of the governance challenges our health system faces. The authors have exposed not only the evidence for their conclusions, but have references for the sources of their evidence which they've presented with clarity. The established facts have been recorded, and the conclusions are unfolded from them in a coherent and compelling manner. The reader cannot avoid understanding the picture that is revealed. This report is a call to action. Implementation will be challenging, but the critical importance of acting cannot be overstated. The cost of inaction would be far greater than that of action. It would jeopardize the realization of universal health coverage. As South African citizens, we have a constitutional commitment to healthcare access and equality for all South Africans. Taking action is fundamental to advancing programs in the Sustainable Development Goals, particularly number 3, good health and well-being, and number 10, reduced inequalities. So, on behalf of the Academy, I extend my deepest appreciation and respect to each panel member who contributed to this study. Professor Lillian Dudley, Professor Flavia Senkobuge, Professor Sharon Fon, Professor Leslie London, Dr. Mark Bletcher, Dr. Genevieve Lawrence, and Professor Catherine Matthews. Your dedication to the health and well-being of our nation is obvious and commendable. Thank you for your generosity. I know you gave up a great deal of brain space and time from research and family in order to accomplish this. Special thanks and respect to our Academy staff for their support and contributions as we navigate this journey to strengthen governance and leadership within the health system. It's imperative that all stakeholders engage, and they have a critical role in driving positive change. Thank you.
Thank you, Professor Glediel, then for that further introductions to the actual report. So now we are going to drill down in the very specifics of the report. So I hope that you've got your seatbelts on so that we can be taken on this journey of exploration of what this particular field looks like and what are the challenges and then what are the recommendations and solutions to the health sector and, of course, the governance and good governance of the health system. Professor Glediel actually just alluded to that, but I just want to emphasize it a little bit further, and that is to say that this work cannot be done if the ASSAf Secretariat is not involved. So then to my colleague, Dr. Kutso Polane, you've been applauded here to say thank you very much for driving this particular panel, etc., over a very long period. And we're all very grateful with all of you that this project's coming to fruition this morning. But it gives me a great pleasure and honor then to welcome Professor Lekan Ayo-Yusuf, who is the chairperson of the ASSAf Standing Committee on Health. ASSAf has standing committees that advises ASSAf and the project officers in that particular subject field of the way forward and what are those critical aspects that needs attention to. Just want to introduce Professor Ayo-Yusuf to you. Previously served as Deputy Vice-Chancellor for Research and Innovation of the Sefaku Makgoto Health Sciences University. He's currently the head of the School of Health Systems and Public Health at the University of Pretoria, chair, of course, of the ASSAf Standing Committee on Health. His focus is on behavioral epidemiology and related policy evaluation for non-communicable diseases, prevention and health promotion. Professor Ayo-Yusuf, I then hand over to you then to highlight the importance of good governance in the health systems.
Thank you very much for the introduction. Good morning. So I'm supposed to sound very intelligent this morning. It's very difficult when you have a panel of experts to launch what they have written and you have to say something. But having said that, it is a privilege indeed to stand here as the chairperson of ASSAf's Standing Committee on Health. At this very important event to launch the consensus study. I didn't know it was that long. It was a little embarrassing, 7 years. But as you said, it has come at a very good time, critical time in our democracy, offering insights and recommendations that would undoubtedly shape the future of healthcare landscape in South Africa. So I'm going to basically go through a couple of things, what health governance is, the elements, why it's important. I want to spend some time talking about the importance of data, challenges, and conclusion. So everybody probably knows this. I don't need to tell anybody, well, most people in this room, what the building blocks are. But I think it's just important that in the journey towards healthier South Africa, we definitely face numerous challenges, but none as crucial as ensuring good governance in our health system. Governance is the bedrock upon which effective, efficient, and equitable healthcare is built. As you can see there, it encompasses the structure, process, and traditions that determine power and responsibilities, or how power and responsibilities are exercised, how decisions are taken, and how citizens and stakeholders in public and private sector have their say to improve health system. And I emphasize stakeholders. Perhaps just to point to this, I think the pointer works. Community and patient, it's key when we talk about health system. And I'm also thinking, when all of this kind of came into being, we did not think about communities beyond just geographical location of people. But the digital space and community is become also quite important. So the decision space and how we govern even the digital space needs to be part of the whole composite. And of course, your patient may not necessarily be physically with you, but digitally with advent of telemedicine. So all of these considerations are quite important when we talk about governance. Good governance in health systems obviously will result in enhanced delivery of high-quality healthcare services, improve health outcomes. More importantly, it's important that health outcomes remain the focus of good governance. It is therefore important in mixed systems like ours. Good governance will ensure private and public health systems are well aligned, ensure resources are used more efficiently in reducing waste and cost. It plays a crucial role in promoting equity and social justice in healthcare. Good governance ensures that the healthcare system is responsive to the needs of all members of society, regardless of the socioeconomic status, ethnicity, culture, or gender. The key elements are transparency, accountability. You get obviously more details and much more nuance of what these key elements are when you listen to the panelists. But I'm just going to go into a few issues that we need to note when we talk about elements of good governance. Most governance frameworks for health systems, irrespective of the discipline used to develop the framework, identify transparency and accountability as the cornerstone of good governance. When policies, decisions, and data are transparent, they foster trust and confidence among citizens, which in turn promotes agency. The COVID period taught us a lot of things, I must say. I started being part of health system and governance when I was a superintendent back in 1998. I think they were talking about hospital board then. I'm not sure whether it's any better 20 odd years after that. And the COVID provides a different perspective as I sat on the Premier's Advisory Committee. Getting data is usually so difficult, even though you are on the Premier's Advisory Committee. If you cannot get it, I wonder how anybody else would get data. So transparency is quite important in governance. People need to know how and why decisions are made. That was a big challenge in COVID. And they should have access to information that affects their health and well-being. And transparency, obviously, closely tied with accountability. Without accountability mechanism, transparency alone is insufficient. We must have systems in place to hold individuals and institutions responsible for actions, ensuring that resources are used wisely and ethically, ensuring there is consequence for malpractice and corruption. And that leads to the next key element, rule of law and ethical standards. Adherence to rule of law and ethical standards is non-negotiable in good governance. Strong legal frameworks and ethical guidelines ensure that the health systems operate fairly and justly. They protect patients' rights, prevent corruption, and promote a culture of integrity within the health institutions. When laws are enforced and ethical standards are upheld, the quality of care improves and the public trust in the system is reinforced. And I emphasize public trust in the system is reinforced. The COVID again taught us how important the trust in public health system is. No matter how much you push for people to do things, if they don't trust the government, it's just much more difficult to get them to do that. And of course, unfortunately, all that happened with the PPE did not help the system. Good governance also means inclusive governance. It requires the active engagement, and the operative word, active engagement, not going to the community once in a while. There should be continuous mechanism to continuously engage community. And the participation of all stakeholders, including government officials, public and private healthcare providers, patients, civil society organizations, and the broader community. And when I say broader community and engagement, it also includes the digital space. It's a skill that anyone in governance should learn. And by involving these groups in decision-making process, we can ensure that diverse perspectives are considered, leading to more comprehensive and effective policy. And of course, I think I must say, just in case anybody's listening to me from the tobacco industry, when we talk about stakeholder engagement and inclusiveness, we have to also ensure that we protect the policy process from vested and commercial interest of industry, be it pharmaceutical or tobacco industry. It is more likely to be achieved when there is universal coverage and this decision space is closer to communities. Another key aspect of good governance is effective and efficient use of resources. Our health systems must be capable of delivering high-quality care without waste. This means investment in health infrastructure, proper management of financial human resources, and the integration of innovative technologies. Efficiency does not imply cheap or cutting corners. Rather, it means maximizing the impact of every rand spent on health services. So I'm going to stop to talk about mapping data for governance to governance behavior. There are cross-cutting, there are layers of governance behavior that requires data, but cross-cutting is data availability that provides understanding or builds understanding of the system. So it's data that gets converted to information. And also data that fosters relationships, how information is exchanged and used to foster management. This, by the way, it's a protocol that is recently published by WHO in understanding how we can use data to promote governance. And I like the model because it speaks to all elements of governance. And then when you come into the top layer and delivering strategy, that's how information is converted to intelligence to actually make decisions and prioritize policies. It provides you, for those who understand the policy circle, how to the information for agenda setting. And that connects to enabling stakeholders because you need information to engage effectively to inform policy when you're consulting. And that information must be in a format that's easily understood by many stakeholders. Not jargons, but easily understood by many stakeholders. And should be present in different forms, including for digital community. The next layer is then once you have a policy instrument that is well informed by data, it should translate to health services and align structures, including financial arrangement. It should inform financial arrangements. And that by itself, it should be bi-directional flow because information from service points should then feed back to strategy. The inner and the core of this governance behavior and the nature of the data that is required is data, it's how information is used for accountability and to empower citizens to promote agency in order to correct any problems within the health system and promote health systems performance. Of course, for all of this to happen is not without challenges. You're going to hear more of those when you get the details of the report. So some of the challenges that we're confronted with and will still likely to be confronted with, and I hope gets to be addressed by the seventh administration. Top is corruption, misuse of resources and unethical practices, political instability. You're in Gauteng. I don't know how many DGs and how many MECs we've gone through. It's very disruptive in governance and policy. And of course, limited resources. We all admit the economy has not grown as much as we would like it to grow. But that's the reason why good governance is even more imperative. Resistance to change, institutional cultural barriers. We have been doing this for a very long time. Why should we change? I'm sure you've all heard that many times. But there are obviously ways to address this. We need to craft comprehensive and coherent policies and strategic plans, and importantly, coherent policies, because oftentimes you might have a trade policy that conflicts with health policy and becomes much more difficult to govern the health system. Investing in training and development of healthcare leaders and staff. I must add, I've seen Professor Eric's book, the ASSAf leadership at UP is one of those, and that's one of the reasons why that is imperative, that we promote good governance. It requires certain skills and behavior. Regularly assessing the health system's performance, as we're going to be doing today, is all going to contribute to strengthening our governance. Engaging with global health organizations and partners for support and knowledge exchange remains critical. In conclusion, good governance is not a luxury, but a necessity for the South African health system. It is the foundation upon which we can build a healthier and more equitable society. As we prepare to delve into the findings and recommendations from the consensus study panel, let us all commit ourselves to the principles of transparency, accountability, inclusiveness, rule of law, and efficiency. By doing so, we will pave the way for a future where every South African has access to high-quality health care they deserve. Thank you for your attention and dedication to this crucial course of applying scientific thinking in the service of society. I look forward to the discussions and actions, and in particular actions that would follow the launch of this important report. Together we can achieve good governance and transform our health system for the better. I thank you.
Thank you, Professor, and thank you for unpacking sort of the, yeah, please don't.
Good governance.
Good governance, indeed. Thank you, Prof. So thank you very much for unpacking so very eloquently the pillars of what is being viewed as good governance in the health system. Thank you very much for that. Much appreciated. At this point in time, I also would just like to acknowledge that there are just about 30 people online. So that's another stakeholder group that we have to monitor as we're now going forward in unpacking actually the report. So I'm looking at the IT guys here on my right-hand side, and you must please just signal me if there's questions or a hand or something going on there from everybody right there. So thank you very much for your assistance as well. So we're starting to drill a little bit deeper now into this report, and I would like to invite Professor Dudley to the podium then. Professor Dudley is a South African medical doctor and a public health medicine specialist trained at UCT and also registered then with the College of Public Health Medicine of South Africa. She's currently an emeritus professor in public health medicine at Stellenbosch University, where she was the founding director of the Centre for Health Systems Development and the head of Division Health Systems and Public Health at the Faculty of Medicine and Health Sciences. She served as the chairperson of the current ASSAf Consensus Study Panel. Not a task to envy, but thank you very much for good work and for bringing us to this point. So Professor Dudley, please could you just join us then at the podium. Please. May I also invite you, after you have given your presentation, is that you'll take questions from the floor. Thank you.
Well, good morning, everybody, and thank you very much, Ms. Veldsman, for the welcome. Thank you very much, Dr. Gledhill, for providing the background on the work of ASSAf, and thank you, Professor Ayo Yusuf, for a really sound introduction to governance, and you've set the scene for us very well. So my name is Lillian Dudley, and I'm going to be presenting on behalf of the panel. Oh, yes. So I didn't notice I was doing a rerun. Okay, I think we're on the right one now. All right. So I am presenting the report from the panel that was appointed by ASSAf, and the title of the report is Achieving Good Governance and Management in the South African Health System. We are going to really provide an overview. The report is quite comprehensive, and I'm really just going to touch on our approach and then try to highlight some of the key findings and the key recommendations that are emanating from the report. But before we get into that, the question that we asked ourselves was why? Why was it important to look at governance and leadership and management in the health system at this point in time? I think we're all very aware that one of our rights enshrined in the Constitution is the access to quality health care. And a great deal of work has been done in the South African health system over the last 30 years to transform the health system, to try and achieve and to address that right. However, when we look at some of the key indicators, it really reminds us that we still have a long way to go. So if we still look at our burden of disease, we still are dealing with a very high burden, including extensive diseases of poverty as well as diseases of development at this point. Access to care, some very vulnerable groups still don't have adequate access to health care. Poor quality of care is unfortunately pervasive in the country. South Africa remains one of the most inequitable countries globally, and this is also reflected in our health status, in access to health care, and our health outcomes. And lastly, even though South Africa spends more than quite a few other middle-income countries on health care, the outcomes that we are achieving are worse in terms of life expectancy, mortality, and other indicators. So something is not working. We're putting a lot of effort, a lot of energy, a lot of resources into our health system. And the question is, to what extent is governance and leadership contributing to some of these challenges? So with that background, the Academy of Science of South Africa provided a brief to the panel. Firstly, to determine and describe the magnitude, the spread, and the effects of the governance and leadership challenges on the health system. To identify effective strategies or best practices that could be leveraged to address these challenges. And then lastly, to make recommendations which are practicable and implementable. So it's not simply a theoretical exercise. We're really wanting to come up with recommendations which can make a difference. And ultimately to improve governance, management, and decision-making so that we can improve the performance and the outcomes of the health system. The approach we used: the panel started off by reviewing the current literature, and we are very fortunate that there have been some excellent reports and some very good research conducted by a range of individuals and institutions. So really to understand both the historical context, the current status, and some of the challenges. We then followed that with a series of consultative meetings with experts in governance, both within government and outside government. And we tried to draw a range of perspectives from the state, from service providers, as well as from clients and citizens. With that very valuable and rich input, we then went back to the literature and triangulated some of the findings that came out of these expert consultations and really explored the literature further to also identify some of the voices that we may not have reached. And here in particular, we were unable to interview the private sector, but we had the Health Market Inquiry report, which had extensively investigated issues of competition, but also governance in the private sector. As part of our brief, the Academy of Science had also highlighted that with the development of the National Health Insurance, at the time it was still a bill, that we really needed to touch on governance issues which needed to be considered as we move towards a national health insurance. So we included a chapter which reviewed strategic purchasing, which for those who are familiar with the NHI Act now, would understand that that is a really fundamental or a foundation of some of the changes which the NHI is proposing. And then lastly, the report was peer-reviewed both by national experts as well as international experts before we were able to finalize it. And very valuable input was provided, which really improved quite a few areas of the report. So starting with the history of health systems governance in South Africa. You can read the very detailed chapter, but really what stood out for us was that the organization and the current governance of the health system is deeply rooted in the country's political history. And that political history is one of colonization, of exclusion, of discrimination, and of extensive fragmentation of the health system over several centuries. So the challenge that the new democratic government faced in 1994 was to transform an extremely fragmented health system, an extremely inequitable health system, into a unitary system, and our white paper does stress that embraces good governance. So there was the intention to ensure that governance was very much part and a priority within this new health system. And we've certainly seen in the legislation that has been passed over the last 3 decades, in many of the structures that have been established, coming out of the National Health Act, for instance, other legislation updating our health professionals' bodies and other structures, establishing the Office of Health Standards, Compliance, etc., have really set about trying to develop governance structures and systems to ensure good governance. So, Prof. Ayo Yusuf has given us some background in terms of what governance means, and we found that there were a range of definitions, and the panel needed to try and reach consensus on how we defined and which definition was most suitable for our context and for this particular study. So we drew on Van Almen, who specified that governance is really the policy guidance to the whole health system, and it's stressing whole health system. It involves coordination between actors, so it involves the people and the stakeholders in the system. It involves regulation of different functions, levels, and actors in the system, and includes the optimal allocation of resources along with accountability to all stakeholders. And what we really liked about the Van Almen definition as well is that he described governance not just as another building block, but really as the building block which really underpinned all others and really created the mortar which held the whole health system together. We also explored issues of whether we were looking at governance of health versus governance for health. So just to briefly explain, governance of health would really be focusing on what the health sector does in terms of addressing health needs, providing health care. Whereas governance for health begins to look more broadly at how we address the social determinants of health and how we govern across sectors, so more about health in all policies and coordinating beyond the health sector. Our brief really started around governance of health, but as we went through this process, we have picked up on some of the issues around governance for health, even though we did not do a comprehensive review of that component, but we recognize that is important and may well need further work within our context. In terms of governance frameworks, we selected the Michelson-Lopez framework, which provides very useful tools for practically assessing governance at a national level and for making recommendations or identifying areas for improvement. So we felt that this was one which really aligned with the brief that the panel had been given. And you will see in this illustration that similarly to Van Almen's definition, Michelson-Lopez also locates governance and leadership as the underpinning building block which supports all the other building blocks which you will see in the center. Michelson also extracted from a range of principles which have been identified around governance as 5 key principles which they felt were particularly important. Firstly, strategic vision and policy design. Secondly, participation and consensus orientation. Accountability, transparency, and lastly, addressing corruption. So these are the lenses which the panel then used as we assessed and reviewed governance within the South African health system. We complemented this by also drawing on a more recent framework which began to look at some of the relationships. And we've heard about trust and relationships being very important as part of governance. So Bigdale's people-centered framework explores the roles and relationships between various governance stakeholders or players. And this guided both our selection of experts that we interviewed, but also provided a lens through which we explored governance both in the literature and with the experts. So briefly touching on what we found in this very rich literature that already exists in South Africa. And some of the reports that we drew on here included reports like the Lancet, the National Lancet Commission on Quality Health Systems, the South African Health Review, 2015 to 2020, and one of the editors is in the room. We also drew on the Health Market Inquiry and a number of other reports and publications. Some of the themes that emerge from those, first of all, everyday governance, which really speaks to governance at the front line, so at the service delivery level, but also at every other level, is relatively weak. So in terms of those elements that we spoke about, there are major challenges. And the frontline governance is, in fact, impacted by weaknesses in governance at higher levels. There's structural issues. The literature also identified some conflicting legislation, which we picked up in the interviews as well. So, for instance, the PFMA and the Public Service Act have provide conflicting authorities to politicians and to DGs in terms of their responsibilities, and undermines governance by creating confusion. Throughout the literature, various publications identified weaknesses in leadership and management, both through a lack of competencies, but also a lack of teamwork and culture which supports leadership and management. Poor governance of key support systems doesn't help. So governance of the human resource systems in the country. And then we've also heard about the desperate need for information and good data to support governance. And even though we've worked on our information systems over decades, we still don't have some of the really important outcomes data that we need to assess performance and to ensure good governance. Procurement systems were also identified as very complicated and often impeding management. We have established a number of oversight structures, but some of the reports identified some of the challenges in these statutory bodies and structures like hospital boards. Community voice emerged as an area which is very weak. Even though we have legislation which creates structures, very often those structures are dysfunctional, they're not working, and we're not providing the spaces for community voice or for civil society. Fraud and corruption, I think we are acutely aware of that, has not been adequately addressed. And then the Health Market Inquiry identified weaknesses in stewardship of the private sector. It's not all bad news. I think it's important that we identify the weaknesses so we can begin to address that, but we were also able to identify numerous examples of innovation and good practice at multiple levels, but more so at local levels where service providers, civil society actually try to overcome some of the governance challenges. And we also have access to some international evidence of effective interventions which we can draw on. So moving on to the interviews. I've told you a little bit about the range of people that we tried to interview, and we really tried to benefit from their experience, their opinions of what was good and bad. And then we drew on that data from them and supplemented that with the research findings to really integrate it to provide a rich perspective of the interrelated issues which impact on governance using the Michelson-Lopez framework. So before we go into some of those findings, I think one thing that really, struck us through our interviews particularly was the complexity of governance in South Africa. So certainly at a political level, organizational level, and structural level. One of the quotes really is focusing on the role of the Minister of Health, but I think really reflecting on what governance should be, stated that he is the Minister of Health, not health care, not private health, not public health, but all of it. So really trying to say that we really need to be inclusive in terms of governance. When we start looking at different areas, for instance, the public sector, the complexity there involves multiple levels with different political authorities within different levels, the requirement for engagement and community participation at each level, also some of the disjunctures which have emerged between the different levels of government. This is amplified by the parallel private and public sectors, which have posed a stewardship challenge. And then, given the huge impact that the social determinants have made on health in South Africa, the need for intersectoral governance further complicates the governance within the health sector. We're one of the few sectors where we are so dependent on the roles of other sectors and really need to find ways to engage more proactively. There's financial complexity. Funds are allocated at a national level in line with priorities, or priorities are developed at a national level, but when the allocation of funds happens at a provincial level, it may not necessarily align with the same priorities. And certainly over the last few years, the austerity measures, and last year I think we were all hit very badly by this, have persisted despite the growing burden of disease and the greater demand for health and health care. Health institutions are one of the most complex types of institutions to manage, hospitals, districts, etc. And then there's also structural complexity, where we've seen some of the overlapping roles and confusion about roles, which undermines good governance and integration. So this is just an illustration of some of the processes that we then used to map the findings against those 5 key principles of Michelson. And I'm just going to try and touch on the main findings under each of those principles now. Starting with the strategic vision and policy design. A number of the experts or key informants felt that we did not share a coherent public value mission across the health system. People spoke about there being multiple plans, being multiple programs, but felt that these were not coherent or adequately coordinated to provide that overall call to action around a particular vision or mission. Very often, because of these sort of uncoordinated programmatic approaches, we tend to focus on what people do rather than the overall goals that the health system needs to achieve as a governance aim. When we started out in 1994, the district health system was really going to be the core of the new health system. So the intention through the various legislation and policies was to decentralize authority and responsibility. But as we've progressed, in reality, very limited delegations have been provided at different levels, at the lower levels, at institutional level. So we have a system where the design really speaks more about top-down decision-making, which is very rule-bound, which hinders innovation, doesn't provide that decision space for managers at different levels in the health system to innovate and to integrate and to take responsibility ultimately. We've mentioned some of the structural problems in the legislation where there may be conflicts. And in terms of institutional culture, along with a sort of rule-bound and top-down approach, very often we focus on the hardware in the system, the financing, the human resources. We don't look at the issues of trust and relationships and how we build teams and strengthen the culture of service delivery. So really a need for a little bit of a shift in how we view the culture of the organizations and the health system. Support systems, I've mentioned those earlier in the literature, but also came out very strongly in the interviews where experts felt that these were not fit for purpose and didn't support good governance, and we really needed to do more to improve this. Weaknesses in a number of regulatory bodies were identified, as well as a perceived lack of independence from the executive. And this really speaks to the fact that the Minister of Health appoints the boards of a number of these statutory bodies, And at the same time, these boards report to and account to the Minister of Health. So there isn't a separation. And in terms of good governance, you really should have a separation between who appoints and who these structures account to. Again, having said that, there are these gaps within the systems that have been established. And again, I just want to emphasize that what we have done is we have put systems, we have put structures in place, but really at this point in time, we're finding that they're not doing everything that they were intended to do, and these are some of the areas of weakness. We also found successful examples of governance in terms of strategic vision and policy design in the local context, where local managers would reorganize the way services were managed, the way services were led, building teams, creating opportunities to innovate. So I think we do have some really good case studies to use in South Africa. Moving on to participation and consensus orientation. Under this, the panel decided to include the perspective of people within the system. So it included the extent to which managers and leaders were able to participate and contribute to policy making, decision making, and service delivery. So it really speaks to that, but we also then looked at the aspects of community and citizen participation. Touching on leadership, some of the experts identified the kind of leadership that was needed, and you'll see in that quote. They felt that leading and managing within the health system is incredibly challenging, and certainly I think over the last decade, with increasing political involvement and interference in management functions, it has been a very difficult space to function in. But over and above that, we have seen incredible instability of leadership, high turnover in very senior positions, which actually has a knock-on effect throughout the system at all the other levels. And we've had the example of Gauteng. I think we had 9 DGs in the space of 10 years. So, it really is something which is a huge problem for the health system. And it's very difficult for these people in these senior positions to push back against political interference, which may have contributed to some of the issues around turnover. However, we also felt that often people were appointed into positions for which they lacked the technical or managerial capacity. So issues of competencies emerged as a concern as well. And then the need for greater team leadership. And this came out from areas where experts felt that they had been involved in or had been part of a process of building team leadership, which allowed more effective management, where visions were shared, where the approach was value-driven, where it was transparent, and where there was a lot of learning and peer support. So a couple of pointers around leadership and management. Around community participation, we do have policies which require that community participation be part of our health system. But in reality, this is not realized. Many of the structures that were established are weak and do not create those spaces. So there are many missed opportunities for dialogue, for contribution of communities and citizens with the expertise at that level to decision-making and governance. Some of these weaknesses around community participation in the National Health Act are unfortunately likely to be carried forward into the National Health Insurance system. They have not been addressed at this point in time, and the NHI Bill and the NHI Act has not actually made provision to address those. So that's something that we need to keep an eye on and try and address as we move forward. But again, we have successes, and there's some people in the room that have been involved in some of these. So, for instance, the Rishitse project, which is a very empowering project with communities actually monitoring the performance of the health services to hold both formal health services and other organizations to account at a local level. And this has really been an incredibly innovative approach to accountability at a local level, which we can learn from. Which brings us on to accountability. One of our experts gave us some really good pointers to how to strengthen accountability, and he recommended these 4 pillars where you have clear performance objectives, you measure them so you have the data, you monitor them, and then you hold people to account by either rewarding that performance or by implementing sanctions. So these sorts of accountability systems, and we may have ones like the Auditor General, the Office of Health Standards, and others, are really intended to be constructive and to try and improve the system. But unfortunately, there is a tendency to also game these accountability systems, and people are not held to account. So we do have systems, we just need to try and see how we can make them work better. We also just need to be reminded that accountability is not just about financial accountability and preventing corruption, but it's also, if you fail to deliver on your public service mandate, if you are not ensuring that people are achieving the health outcomes or accessing the health care, the quality of health care, you are not being accountable, because you are answerable not just for your compliance with financial regulations, but also with achieving those overall public service mandates. Accountability also emerged as a problem where in the appointment of managers in particular, which was linked to political interference. And this also meant that appointees were not accountable because they were vulnerable to some of the vested interests which had ensured them securing their particular positions. Oversight bodies, and here at a political level, our parliamentary system has functioned, but there are certainly weaknesses, and we saw this with the Digital Vibes, the PPE corruption case, where the Parliamentary Portfolio Committee failed to hold political players to account. And I think this has come out in other areas where you're in the same political party, it becomes very difficult to ensure accountability. So ultimately, we can't have one or two accountability structures. We need a range of accountability structures which are complementary and which ensure that there are checks and balances. And we have had some very valuable information, and investments have been put into reviewing some of these issues. So, for instance, the Health Market Inquiry report is available on the private sector, but none of the recommendations have been implemented to date. And I think this has been flagged previously because, in fact, a number of issues could have been addressed in the lead up to the NHI from that particular inquiry. And then we also have committees where some of the experts felt that committees were toothless, didn't have the powers, didn't have the resources to act. Moving on to transparency. And we've heard a little bit about transparency. The key issue that came out, and we've touched on this already a little bit, is that appointment processes, particularly in the public sector, are insufficiently transparent. So over the last while, appointment processes have been victim to cadre deployment and patronage networks. And the consequences of this is that we end up with people in very, very important positions who aren't able to deal with some of the complexity and the challenges that the health system faces. We've also heard a little bit about the importance of health data, and in particular having outcomes data, so that we know what the performance of the health system is, so we can be using that for not just monitoring performance, but also going forward for contracting. So very important that we do actually begin to focus on how we measure and monitor. And then the last principle was around corruption. So the overall sense was that we are not acting on corruption, so we need to be preventing corruption, we need to identify it when it occurs, and there need to be consequences, there need to be mitigation. We can't simply rely on whistleblowers. However courageous the whistleblowers in the health system have been, there hasn't been adequate protection for them, and that is something which also needs to be addressed. And people who have taken a stand, we've seen the dire consequences for Babita Deokaran, but we've also heard that many other people who have taken a stand, refused to sign off, have simply been moved or demoted because they've tried to prevent the corruption. And very often, it's not just that people in the system, or particular individuals, some bad apples, are dishonest. The problem is when you also have people that are not competent in their positions, they're unable to recognize when corruption is occurring and are unable to take steps to address it. So corruption is not just a factor in terms of dishonesty and unethical behavior, it also relates to competencies of management. So we really need to be looking at how we address this to prevent and to create an environment that makes it difficult for corruption to thrive. Coming out of the discussions, a couple of key themes emerged, and I'm not going to read this very busy slide, but essentially important strategies that emerged were that, A, we need to get the systems and the structures right to ensure good governance, but we need to get the right people with the right competencies in the right places, and we need to empower those people, whether they be individual managers and teams, with appropriate systems and tools. Before we move on to the recommendations, I'm very briefly going to touch on some of the governance issues for the NHI, which I spoke about earlier. And you'll see this is a very important chapter in the report, and it was led by Dr. Mark Bletcher from Treasury with a team of experts in this area. And I'm just really going to touch on the key issues, and you can direct the questions to Mark a bit later. But as you're aware, strategic purchasing is one of the mechanisms underpinning the national health insurance. And it really speaks to having an active or intentional process of purchasing, which is linked to the achievement of strategic objectives. So it may be linked to performance, it may be linked to achieving certain targets. So it really tries to ensure accountability as part of the procurement and purchasing process. And as we're moving into a process of contracting with different sectors, this becomes very important. So the NHI does ensure or proposes a purchaser-provider split, which then allows you to have the NHI fund purchasing and providers being separately. It changes governance powers and functions across spheres. So this is really an area that we need to be looking at very carefully. If we're saying that we have challenges with the current governance powers and functions, we shouldn't be taking those problems into the new system, and we really need to be ensuring that that decentralized delegation of authority to district health authorities and purchasing bodies is effectively implemented. It needs to allow for greater autonomy of larger hospitals as contracting institutions and ensure that their boards and CEOs have the necessary authority for that. We're needing to develop new payment models, and for this we need extensive information to be able to measure whether it's a population need, workload, performance, etc. And then we're moving towards a mixed provision model with the NHI fund purchasing from both the public and private sector, which should allow for more competition if we can implement and provide good governance of the NHI and strategic purchasing. So what do we actually need? We need stronger, semi-autonomous provider institutions which will require new legal status for many of these institutions and new forms of governance. We need to have contracts which include objectives and performance targets as a legal basis for contracting. We need to link funding and performance through reimbursement reform. So currently, our current legislation doesn't allow us to do that, and if we want to use strategic purchasing and governance of strategic purchasing, that needs to be reformed. We need information systems which provide the kind of data that is needed around quality, value, or achieving specific targets. And we need to build capacity. Currently, we don't have the capacity for strategic purchasing in the public sector. I'm not sure about the private sector, doubt it very much. And this is something which is fundamental to starting to implement a new system. Other issues for governance of the NHI. The NHI fund has to have sufficient independence from the provision side, and this is one of the issues that has been raised, that, again, the Minister appoints the NHI fund board, and the board accounts to the Minister. We've seen in other countries, and it'll come down to autonomy as well, that countries like Thailand have a range of other stakeholders who serve on the board, so that the fund is in fact accountable not to the provider, but to society as a whole. Governance, the NHI board needs to have appropriate governance functions. There needs to be transparency and accountability, and there needs to be community voice or user voice in the management of the NHI fund. Changes to the powers of the different spheres of government need to be clearly delineated, and already there are some shifts in functions without these being very clearly spelt out and legislated and carefully managed. Autonomy, institutions like hospitals, which are going to be contracted, need greater autonomy, and ultimately procurement, which is one of our areas of weakness at the moment in terms of corruption and efficiency, really needs to be shifted towards the strategic purchasing model, so that we're not using the current models which will undermine the success of the NHI. So summarizing all of those findings, under each of these principles, in terms of strategic vision and policy design, the key issue that emerged was the absence of a unified public vision, as well as inadequate delegation of authority to levels where decision-making occurs, and these impede effective governance. Transparency and accountability, political interference has been a huge issue, which has undermined accountability and trust in the health system. Participation and consensus orientation, we need to strengthen community involvement, and we need to shift the culture of management from a top-down hierarchical approach to a more participative management style within the health system. And lastly, we need to very seriously address corruption, which remains a significant issue, and provide protection for whistleblowers. So in summary as well, the governance system is very complex, and we've identified a number of weaknesses. We've also identified some good practices, but we do believe that the foundations are in place for good governance. We, however, do need to very seriously and urgently address the failures that have been identified. The National Health Insurance Act now presents a range of new governance risks, but at the same time, it does present us with opportunities to reset some of these governance systems and structures. And along with that, we can now begin to look at more innovative and inclusive approaches to governance and design the governance system better for the current context and the challenges that we face. So moving on to the recommendations. We all recognize that universal health coverage and access to quality care is a constitutional imperative, and we need good governance and leadership to achieve that. We can simply sit back and say, well, c'est la vie, things are okay, but doing nothing is actually going to come at a huge cost. We do need to address these issues if we're moving forward, not just for the NHI, but to begin to improve the performance and trust in the health system. So with the political shifts as well, we have an added opportunity currently and a window of opportunity to reset these governance systems, to future-proof the health system. And a great deal of commitment is needed, political commitment at other levels, and effort so that we can achieve this. Okay. So our key recommendations then, first of all, is to develop a common public vision for the health system. And in order to do that, engage all sectors, partners, and stakeholders in working towards this common vision. And I'm sure there's already quite a lot of common ground, but it really needs this process so that we can all buy into it, we can all share it, and we can all work towards it. We do need to update some of our legislation and governance structures so that they're more fit for purpose and insulated from vested interests, and have more executive authority rather than advisory functions. We need to delegate authority appropriately to each level and within levels of the health systems so that managers can manage, that they can do their work and be accountable and responsible. We need to get ethical people with the appropriate competencies into leadership and management positions in the health system at all levels, but critically at the top levels as well. And then we need to surround these managers and leaders with systems which enable them to work effectively and to ensure good governance. So the human resources, procurement, health information, etc. And we need to start working on the software in the system more. So building teams, attending to relationships, both within the services, between the services and other stakeholders, and to start moving away from this very command and control and punitive approach in many instances, which creates fear and prevents managers from being innovative. And then lastly, we also need to authentically engage communities in participating so that we have appropriate, respectful, and responsive health services. And as we saw with the Rishitse project, we have capacity to monitor health service outcomes and processes and are transparent about sharing that with users of the services. And then lastly, we need to have measures to prevent and to act on dereliction of duty and acts of corruption and protect whistleblowers. So that might sound very simple, but it is quite a lot. But I think what we are saying is that if we don't address these issues, we will not be achieving the goals of universal health coverage and quality of care and improving the health status of the population in the country. So we really need to be serious about this. Doesn't need everything to be changed overnight, but we need to start. And we need to work steadily at making these shifts and changes. I think what emerged, particularly from our interviews, was that there are many people in the health system who have the skills, who are competent, and who really want to work hard and work ethically and improve the health system. And really we need to provide these people with the opportunity to do so. And lastly, a bit of a challenge. So, what are you going to do? What is your role in improving governance? So if not you, then who? And if not now, then when? We really do need to stand up and say, me and now. Thank you.
Thank you, Professor Dudley. We have a couple of minutes. I will allow one or two questions perhaps for clarification before we actually move on. Please raise your hand if you have some questions for clarification. Okay, if not, then we can move on with the program.
Thank you. I was going to ask the panel to answer.
Thank you once again, Professor Dudley, and of course the panel for your absolute good work. I must say you had a myriad of aspects to bring to the fore, to sieve through them, and to decide which are those important ones that needs to be highlighted in terms of good governance of the health system. So congratulations. I think you've done an incredible and an exceptional job in unpacking this very critical aspect of our health system. So thank you very much. So we're fast moving on now, and we have a panel discussion right now. And first of all, I would just like to very briefly introduce our panel to you. So our chairperson of this panel discussion is then Dr. Pillay, that leads the Bill and Melinda Gates Foundation efforts to strengthen TB and HIV program delivery globally. He joined the foundation in 2023, and he served as the South African Country Director and Senior Director for Universal Health Coverage at the Clinton Health Access Initiative. Earlier, Dr. Pillay served as Deputy Director General of Health in South Africa's Department of Health, where he was responsible for health programs. I would like to invite you then to the fore to start perhaps to sort of position yourselves here then for the panel discussion. Then I would also like to invite then to the podium, or to the front then, is Mr. Yawa. Anele Yawa is a South African human rights and social justice activist based in Johannesburg. He joined the Treatment Action Campaign TAC in 2002. He has worked for TAC since 2002. He is currently the General Secretary and the Chief Accounting Officer for the Resetswe Project, a consortium of 5 organizations serving the needs of people who are living with HIV. Dr. Mzukwa, if I can invite you to the front, please. He's a general practitioner practicing in a private practice in Durban. He received his medical degree at the University of KwaZulu-Natal and is currently busy with his master's in diabetes at the Warwick University, and is also the chairperson of the South African Medical Association and as board member at the Foundation of Professional Development. And then if I can please invite also Professor Maswime. He's a full professor at the head of the Global Surgery Division of UCT and an obstetrician and gynecologist, and a member of the Academy of Science of South Africa, Vice President of the Women in Global Health South Africa, and member of the FIGO Committee on Ethical Aspects on Human Reproduction. She has received also the Young Achiever Award by the President of South Africa in 2017, and the 20 Young Shapers of the Future in Health and Medicine by the Encyclopedia of Britannica, and she's chairperson of the Health System Trust. So very welcome then to our panelists, and I'm handing over now to Dr. Pillay to please direct and the panel discussion as well. Thank you, sir.
Great. Thank you.
Is your panel okay? Or would you like to
No,
move
okay.
a little bit out?
No, maybe they can move a bit.
No,
Salumi is a bit squashed.
It's
A bit squashed. Well, thank you very much. Good morning, everyone. And firstly, congratulations to ASSAf and to the members of the panel who wrote this terrific report. I think it's an excellent report. It's obviously an indictment on, I think, many of us that we are where we are currently, 30 years after our first democratic election. Firstly, thanks to my panelists for agreeing to be panelists. And I think many people have said so before, but let me say that there might be a Minister of Health or a Deputy Minister in the audience. We never know, right? We will know soon. And maybe one of the panel members might be. So we should take this seriously. But more seriously, I think it's, given the nature of the report and the recommendations, I think ASSAf and all members of the panel should, once the minister is appointed and the deputy minister is appointed, share this report with the new minister and also the incoming portfolio committee, because I do think it requires a reset, as the report suggests. And I think we will all step up if the leadership requires us to step up. So that said, let me ask the panelists to reflect on the report, because they've all had copies of the report and you've heard Professor Dudley's summary of the report. So let me ask my good friend and global surgery counterpart, Prof. Mswemi, why is it that 30 years after democracy, it seems as though we've achieved very little in terms of good governance and management? And do you agree with the recommendations of the report? And if so, which is the one recommendation you would like us to prioritize?
Thank you very much. Thank you for inviting me, and congratulations to the team as well on this excellent report. It was very sobering to read, as you can see and as you've heard. But I think it's very important, and I think you highlighted and raised so many important issues, things that many of us know but are afraid of saying, things that many of us wouldn't have been brave to say. So even being on this panel, considering that in the next few days we'll have a new Minister of Health, one had to consider carefully whether to accept or decline the invitation. But I think for me, there are three things, that summarize the report for me. And I'll be a bit philosophical before going into the actual detail. But I think the first one for me is investment in leadership and management, So we all come from a clinical background or from a medical background. We know how much time is spent on training you to be a good clinician. But we just assume that leadership skills will be gained along the way. And I firmly believe that leadership and management can be taught. I think when I read, there's a section where they talk about, you're expected to look after a budget of 200 million. I think myself as an obstetrician, with a PhD in obstetrics and gynae, if you gave me a budget of 200 million, I'm not sure I'll know exactly how to manage it. And I think those are some of the mistakes that we make, that we teach you how to run a service, but we don't prepare you how to lead a service. We separate the teaching of leadership from the clinical teaching and assume that along the way people will gain the expertise. And what we've seen is that that doesn't happen. And then values is the second thing. We talk about corruption, transparency, accountability. It's all about values. Who matters to us? What matters to us? What are we going to allow under our watch? What are we going to allow to slip under the carpet? And I think we really need to introspect, because this report is not a reflection of just our leaders. It's a reflection of all of us. And if we keep quiet and if we allow this to happen and continue, it also says our values are questionable as a community and society. Then the last thing for me is the commitment to a healthy governance. And how committed are we as South Africans to having a healthy governance? All of the recommendations are implementable. There's a lot more that can be done. I'm surprised that you summarized it into such few points. There were a lot more things that you could have added. But how committed are we as a nation to having a healthy governance and, of course, a healthy society? Thank you.
Salome, thanks very much. Dr. Mzukwa, assume that the president on Sunday tells the country that you are the new Minister of Health. Of the 7 recommendations that the panel made, which one would you prioritize?
Thank you so much. I think let me first thank the real panel that have done the work. I think they've done a sterling job. We're all aware of the issues that have been raised. I think they were detailed, and it showed the time that was taken, to compile the report, and also the work that was done as well. I think the most important part, I think all the recommendations are important. I must stress that. They are very important, but I think what stands out to me was the issue of policy design. I mean, there's issue of strategic, of vision and stuff. But what came out with me was the issue of policy design. And I say that because we have the NHI in front of us, and you can pick it up from there that lots of work was supposed to be done in terms of the policy design. I am saying this because when it comes to consultation, I think I gained this from leading a membership organization. In a membership organization, you've got to consult all the time if you're bringing up changes or suggesting changes, or even listening to the members, what is it that they want, So, but what we've picked up from this was the fact that it was just a tick box exercise. The engagements were not meaningful. It was just to say what is it that is required by law. So we just ticked the boxes and we moved on. But the problem is when it comes to issues of policy, you want to, if I may, use the term that is used in the business sector of co-creation. You want to co-create, right from the beginning, the thinking of the product, the design of the product, and moving on to other issues. Because why you want people to co-own, to co-understand, which is not what we have seen with the NHI. And many other issues that are brought up, people have been talking about the top-down approach that is being used. You just given say, this is what we are going to do for you. And you are supposed to be wagging a tail of recognition and say, this is what is needed. There is no space for professionals to express themselves. I mean, if you look at, we just in summer we just had an interviews for the CEO of summer. To me, it was amazing because we were sitting with a number of them, not knowing who actually to pick up, because these people are just, all of them, they're just good, and we were wondering who is the right candidate amongst these people. All of them are good. What I'm trying to say is that there is a lot of intellectual capacity in South Africa, which is not used in academia everywhere. There is lots of, those people don't have to be employed, because what I think people are doing is they are looking into government structures, yet we've got so much talent, intellectual capacity outside of government, which I think we can, as an association, we've been doing that, assisting there and there, but at times we feel sidelined. At times we push ourselves to be involved in decision making. I think that's what was outstanding for me. Thank you.
Thanks very much. Now my comrade, Anele, you also might be called. So, Anele, you've led a very successful, and you've heard references to it as well already, the community-led monitoring, report, and accountability movement that you've been leading in the country. Is that an example of good governance? Is that something we should be building on? And have you had good experiences at provincial and national government level when you raised issues that came from the ground?
Thank you, comrade Jorgen.
Anil and I go back a long way.
And greetings to everyone. I think I must echo the same sentiments with my comrades on my left. Thanks to ASSAf for appointing the panel which produced this report. I can safely say 80% of the things that are on the report is what I know. And I'm saying this from a perspective of being a public healthcare user and a perspective of being a community member. If I were to answer to your question, Comrade Jorgen, amongst other things, there are two main recommendations from this report that I am interested for them to be implemented. One, it is around patronage and cadreship deployment. Two, it is around corruption. The problem that we have in South Africa, and you will forgive me, I'm not going to mince my words. I will say things the way they are. And I'm prepared to face the consequences. One, yes, the ANC-led government, post-apartheid, took us, the people of South Africa, from where we were, and everything they did with the ANC health plan, the white paper, integrating the 4 provinces and homelands into 9 departments of health, which is 1 national and 9 in provinces. It was of a good intention. But the problem, and there is a lot of good things which the ANC-led government did, but the problem in that process, they had appointed civil servants and public servants who never had the best interest of the people at heart. If health is a fundamental human right, we must ask ourselves, how did it happen that some of the public servants who were appointed never had credentials and academic qualifications, but they were appointed based on their close proximity to the politicians or based on their struggle credentials? This one was in exile, this one was in Robben Island and all what have you. And as the result of that, those people never had good qualities of delivering quality healthcare services to our people. And leading to that, these people ended up looting. We all know how Brian Hlongwa, when he was the MEC of Health in Gauteng, he looted the public purse. What did he do about that money? Some of that money he donated it to the ANC. And we expect the ANC to hold him accountable. Yet the ANC are the beneficiaries of the same money that was stolen. That will never happen. We all know how Qedani Mahlangu massacred mental health care users at Life City Main. Who benefited from that? The ones who benefited were bogus organizations that were created by the comrades, looting from the public purse to give to the comrades, whilst on the other hand, the majority of the people died. We know how Dr. Zweli Mkhize facilitated the process to make conditions favorable for the digital vibe to loot from the public purse in order for his comrades and his sons to benefit. And we all know the scandals of the PPEs, how the former spokesperson of the president and her family and many others benefited on the PPEs. The money that was meant to save the lives of the millions of people, it never went to where it was supposed to go, but it went to their pockets. But the question we must ask, who was the beneficiary? Because all these comrades, when they loot from the public purse and go to the Treasurer General of the ANC to donate. And you expect the ANC to hold such people accountable? It will never. We all know why today in Mpumalanga there are no medicines in most of the health establishments. It is because the former premier of Mpumalanga, who is now the spokesperson of the National Council of Provinces. She looted the money that was meant to purchase medicines. And part of that money, she donated it to Abofikile Mbalula and others in order for them to be able to second her, for her to be either reappointed as the premier or be appointed to a higher position. The problem that we have in South Africa, we have leaders who are good in coming with good policies. But when it comes, those policies to be implemented, we cannot see them. How many commissions did our government appointed? Zondo Commission. We all know that not long ago, Zizi Kodwa resigned as the Minister of Sport. Few days ago, he went to Parliament to be sworn in. What about the step-aside rule? If it was right for the ANC to remove Ace Magashule based on allegations leveled against him and force him to step aside, why the ANC is not applying the same principle? I am glad that after 29th of May, we've got the so-called Government of National Unity, with the hope that the Government of National Unity is not going to be like the majority party which governed our country for more than 30 years. They will be able to hold each other accountable. But in the main, we need to begin a health revolution. If President Cyril Ramaphosa and his cabinet, MPs and MPLs, if the public servants are able, firstly the public servants, my doctors, and some of the doctors here, some of you are working in the public healthcare sector, but when you and your families are sick and dying, you don't go and access healthcare services in the same establishments where you work. Same applies to the ministers and the politicians. They make policies for the majority of the people. Yet when them and their families are sick and dying, they don't go straight to the public healthcare. The problem, it is because of the policies. If we want to fix the broken public healthcare system of our country, all of us, we must go to the public. I so wish when I'm sick and dying, I can be on a queue with Cyril Ramaphosa here, with Panyaza Lesufi here, with any other person who is rich, so that when we are told that there are no medicines, all of us can feel the same pain.
You can always depend on Comrade Anele to speak truth to power. Thanks, Anele.
I think.
So pass it back on. So I think, Anele, you also hinted at some opportunities that we have going forward. So can I ask Dr. Mzuko, what opportunities do you see for us to fix the governance and management problems going forward that we should prioritize?
Well, am I audible? Okay. Well, I think we've been talking a lot about professionalization of the public service, and I think it should not just be a sentence in one of the manifestos. It should materialize. I think that's the first place. We do need a lot of work around that, but also we do need to look at the difficulties of implementation. I'm looking at whatever is done. We've got recommendations. You can talk about the Mayose report on HPCSA. You can talk about the HMI report. All these reports, and we've got launches where we attend. There's a minister, and they remember also Professor Mahoba whilst he was still the health ombuds. It was a scathing report. Minister shakes hand, and there's a promise of implementation, but nothing is happening. I think we are not big on implementation. I think that's where we need. We write lots of good reports. Even if you look at this one that was written by ASSAf, it's a very good report. It needs somebody who's going to sit down and say, what is it that we can do? Because we're spending not only time, money on these things. We're spending time. People are taken away from their families. Prof. Mayose lost his life. But he dedicated a lot of his time, which is the time that he should have spent with his family. trying to change, transform the healthcare system by pointing out failures of the system. But it's not happening,
So what do we need to make it happen?
That's what I'm saying. That in the first place we need to we need to start at professionalization, but also we need to force ourselves. For example, the associations. We do need to step up and say, with decision making, we want to sit there with the users of the healthcare system. They need to demand their space there, because if one of the issues that were highlighted by the report is that there's been, the healthcare users have been sidelined in terms of communities and stuff like that. So we need to force ourselves, all the stakeholders in the healthcare system. This is not just, we've elected government to lead on our behalf, but it can't be that we are going to allow government to just do as they wish and not hold the government accountable. So I think we've been sitting, relaxing. It's time that we go forward and force ourselves to be part of these engagements and be part of this decision making.
Great. Thanks very much. So, Prof, as an academic and as the chair of HST, what do you think organizations like HST can do? What opportunities are there for organizations like HST?
Thank you very much. So I think, the NGO sector contributes a lot to South Africa. It being very proud of being part of HST and the work that we do, providing evidence, supporting, giving technical support, improving access to care by actually providing actual services where services are required. Innovation is a big part, because we know that our governments, in no country, there's no government that can afford really to provide all the healthcare needs for the entire country. So there needs to be that shared commitment between NGOs and other organizations, the private sector, but we can work better together to support. I think what is required is that we all understand what the strategic vision is. So what is the real state of healthcare in South Africa? What are the key priorities? Where are we going? What are we trying to improve? Because on one hand, a lot of work has been done to strengthen primary health care, but there's a lot going on. There's emergency services that need to be strengthened. There's surgical services. There's a lot of other areas, but none of us often know. If you ask any of us in this room to say, what is the key area that needs to be focused on in South Africa, we'll have different answers, because the vision and the direction and the priorities are not well understood. And once we start coordinating better, then we'll be able to work towards shared goals. And I think that's what needs to happen.
Great. Thanks very much. So I'd like to thank the panel very much for their reflections on the report, as well as the suggestions for what needs to be done going forward. But don't leave where you are sitting. The next session till 12:05 would give the audience an opportunity to raise issues, ask questions of both the report writers, people who wrote the report, the panel, as well as my panel up here. And any comments you wish to make. I spoke to Mia Malan of Bekasisa just before the elections, and I said, I'd like to write a short document that you could consider publishing the day after the elections about what needs to happen, or what should the new incoming minister do. And one of the things, and I'm very glad that the report that I read over the last couple of days resonates quite well with what I said in that very short document. So it's validated. You validated what I was thinking for a while. But one of the things I said in conclusion is that after the elections and after the appointment of the new minister, etc., the new minister should call a meeting of stakeholders to reset what's going on. And I think this report will provide a good basis for that discussion and for that reset process, with hopefully some very concrete actions that we can hold leadership to account for going forward. But let me just ask the audience, please raise your hands, and if you wish to make a comment, ask a question, make a suggestion, please feel free to do that between now and 5 after 12.
Jürgen, why are you excluding yourself from the list of ministers?
No. I'm definitely not a potential. So let's start. Yeah, please go ahead. Please say who you are, where you're from, and ask your question or make your comment.
Good morning, colleagues. I'm Professor Boshomani. I'm a nuclear physician, currently...
Please hold the mic close up so we can hear you.
Is this better?
Yeah.
Okay. I am a nuclear physician, currently at the University of Limpopo. And I am also the technical member in nuclear medicine for BRICS. So the comment that I wanted to make, it's to start with Professor Maswime. We've known each other for a while, and she's somebody that I consider a friend and a colleague. She also happens to be quite humble, because I think that if you were given that 200 million, you would be one of the people who will know exactly what to do with the funds. And also, I have to say that Professor Maswime started the Clinicians Scientist Society in South Africa. So she's somebody who's very competent, and someone who also happens to be humble. So there I was just saying that you know what to do.
I thought you were voting for her for the ministry.
I think she inspires a lot of people. And then my second comment will go to Sama, and I think it's Dr. Mzukwa. Your comments regarding that SAMA has been looking for a competent CEO for several months, and also the CVs that you received were all of very competent people. I'm a SAMA member, and I do know a few people who actually put in their application. And having been a member of SAMA since...
I think you should have a private conversation with Dr. Mzukwa about the CEO position.
Since I've been a member of SAMA since my years when I was an executive as Judasa. SAMA is actually quite an effective organization, and I think it can also drive a lot of positive changes that were identified in this report. I know I'm not saying that SAMA should start another strike, but I know that SAMA in actual fact has got ways in which it can actually influence government to do the right thing. And then lastly, it was Mr. Anele Yawa, comrade. Maybe it's easier if I put it that way. I would like to thank you for your honesty, and also the way that you eloquently stated the problems and not afraid. You were courageous, and at some point we need to have conversations in the manner that you actually approach them. I think before we change anything, we actually need to be firm and have those courageous discussions. Then I think a lot of things will also, that were flagged within the report, change for the better.
Great.
Thanks
very much, Prof. Thanks. I'm not sure who was... Oh, yes. If you could pass the mic forward. Yeah, please tell us who you are and make your comment. Yeah, it's you. Yeah.
Thank you very much. My name is Dr. Kanyisile Shabalala from the University of Pretoria. I just wanted to have 3 short comments. The first one on the comment on making the public sector more professionalized. And I agree, it's very important. But I think together with that, which is what was said in the report, is that people are given responsibility, they're given accountability with very little authority and very little decision space. So it's very difficult for professionals to take on that kind of accountability without the appropriate decision space. So I think it's absolutely true, but the two need to be coupled together. I think the second thing, we spoke a lot about data on health outcomes and being able to monitor and evaluate as we go. But over and above that, I think having specific indicators for the governance structures, that is very lacking. For example, if you look just at Gauteng on what we track for governance structures, it's whether they exist or not. Nothing further on functioning, nothing further on effectiveness. So certainly indicators and monitoring frameworks for the governance structures and their contribution to health systems performance is key as we go forward. I think lastly, a very important point which was raised by Anele, very colourfully, which I don't think I'll be able to do, was the role of politics and how it influences governance arrangements and the delivery of governance. We know that within the system, you might have within institutions someone who's senior with their subordinates, and then when they sit in the political structure, the subordinates are senior, and they are subordinate. And that makes for very difficult and complex governance arrangements and delivery. And so I think the effect of politics is one that has to be acknowledged and also one that has to be diluted. I'm not quite sure yet as a collective if we know how we do that, but certainly the politics and the way it influences governance and delivery has to be diluted.
Great.
Thanks.
Great points. Can I ask the panel members who wrote this report? You told us the why. You told us the what. Can you give us some hints on the how? Can you give us some sense of what you think the new minister should do with your report before we go to additional comments? Any of the panel members? Oh, Sharon, we will unmute you, and I'm not sure whether you want to answer the question I just posed, but if you do, please go ahead.
It is. Do you hear me?
Yes, we can. Loudly.
Great. I'm not in control of the sound levels. I think your point, and really in response to Anele as well, I think the first thing is to set up structures such that they are insulated from vested interests. And I know people have focused a lot on corruption and the role, perhaps Anele was pointing to the role of the ANC, but the structures that we have to have much more insulation from vested interests. And in the report, we speak about how that happens. We speak about the role of boards, that people who can appoint are different from the people who can remove someone. And you've got to imagine all the structures that we have being reset such that you imagine your enemy is in power. I often use this phrase of when you get married, people have a pre-marriage contract, an antenuptial contract. That contract is not for the marriage. That contract is, what if we get divorced? And I think what we've often done in setting up the structures is to assume that the people who are going to be serving are those people who are going to be those ethical, committed, hardworking, competent people. Let's start thinking that the person who's going to be sitting somewhere is going to be competent at some things, not competent at others, subject to influence, in other words, a human. And in those circumstances, we absolutely have to set up structures that allow for accountability. And that's one of the places that I would start. The second place, of course, is to develop a common value mission. So that's in response to what I think is a really important and practical suggestion that we've made, recommendation that we've made in the report. Thanks, Jürgen.
Thanks very much, Sharon. From the panel, any other key actionables that you want to highlight? Leslie? No, you're getting a mic. I think you need to hold it very.
Okay. So I totally agree. My comment is only that we need to get away from the kind of short-termism issue, because whether it's a politician or a senior public servant, we get to be asked what is it that we can do quickly. And this is not a quick fix. This is a lot of fixes, and it requires time and it requires staging. So what Sharon is describing, yes, but we also need that investment in leadership. You know, we're not going to get ethical people out of the air. We're going to have to work at it hard, quite hard. And that requires all of us. So I come from the academic sector, but the NGO sector as well, to try and make sure that that is built. And then the accountability from the top, this idea that senior politicians can just move their heads of departments around when they start getting too bolshy. That's actually got to be something which society doesn't accept.
Great. Thanks, Leslie. Any further comments from the audience, and then we'll give the panelists one last chance to react. Okay, but you already spoke, Hayo. You told us what governance is already. We believe you. We'll come back to you if we have some time. Mark, yes.
Thank you very much. My name is Dr. Ziyanda Mgugudosello, and I'm from the South African Medical Association. So thank you very much for this report. I think for me, what I appreciated the most was even just the definition of what governance is. Being defined as stewardship, right? And I think that's something that, we would need to communicate to the new minister so that he rallies up his people so they understand that they're actually providing stewardship over the health system. And then understanding the relationship between the management and the leadership aspects within healthcare. Because as Dr. Mzukwe has already said, for example, with SAMA, we've got managers and leaders in different levels of the health system already. So the question then becomes, where to from here for us? We would need to capacitate the people who are already in the positions, right? We capacitate them, we empower them, we support them to be able to do the work that we know they can do. The difference between the corrupt people and the not corrupt people is that the corrupt people work together and they take everything by force. The ethical people work in silos, and that is why then they get ejected from the system. So we need to be wise and to be smarter. There is visible and invisible power. We've got to use that power. Thank you.
Great. Thanks very much. Mark Blecher from the Treasury had his hand up. Mark?
Hi. Thanks, Jürgen, and good morning, colleagues. Just one of the practical things that I think needs to be considered in the evolution to the NHI is, whether the NHI is genuinely going to be doing strategic purchasing, which is its intention. And for example, if the fund or if a province is going to purchase services from, say, for example, an academic hospital, that's not just a question of payments flowing, for example, according to a new reimbursement mechanism, but it implies a totally different governance relationship. For example, from the side of the hospital board and hospital management and the fund as a purchaser, for example. So we may well need to see semi-autonomous, for example, academic institutions. We've seen, for example, historically under the Academic Health Complexes Act, that act has never been implemented. So that even with large academic hospitals, we currently have very little powers, and the hospital boards tend to be advisory. They have very little powers. So if we are to have true strategic purchasing, we need to look very substantially and practically at how those contractual and purchasing arrangements will work, how the powers of the new of the management of these institutions and the boards change to enable that to happen. Otherwise, what we're going to happen, otherwise the whole NHI is going to end up as kind of an expensive experiment, but it's not going to yield the results that were originally intended. Thank you.
Great. Thanks very much, Mark. There's some comments in the chat. I'll just read them out. Any good practices that were noted with regards to addressing corruption in both the public and private sectors? And next comment is political interference has been highlighted in the report. What is the recommendation in addressing this major challenge to good governance in the health sector? And I'll give the last word on both those issues to members of the panel who drafted the report. So the first is any good practices in curbing corruption, and the second is how do you protect people from political interference, with that, which I think Sharon, at least in part, responded to.
Thank you. I actually wanted to comment on another aspect of the implementation, which I think really came out in the data, was the relationships and the attention to the software. And something that one could do pragmatically in healthcare facilities is a renewed focus on organizational development, change management, and team building, because there's often a volatile and hostile environments that healthcare workers have to work in, and they also need, the desired attention, and also to renew the relationships between them and the users of those services. So I think especially now with the recent budget cuts, the volatility and the relationships have been tarnished even more, and I think that would be a place to start, with strategic planning and organizational development to address team building and break down the silos that typically exist in healthcare facilities, by the same time reaching out to the users and engaging more with them in various platforms, besides the community participation, but the actual users in the facilities.
Brilliant. You answered one of the questions on the chat. The question is, or the comment was, team leadership was identified as an approach in building leadership in governance. What investment is required to build team leadership within the local context to enable responsiveness to local challenges? And I think the report highlighted some good practices at local level, many more than at national or provincial level. So
I just wanted to touch very briefly on the question on corruption, Yogan. And I think as a panel, we realize that it's not a one-size-fits-all. It's not a one tool to fix something. And there's this layered approach, as Sharon was saying, first the architecture, then nextly, as Leslie said, that pipeline of ethical leaders. But at the same time, we shouldn't forget, as Lillian presented, that whole protection, because there has to be a whistleblower to say, hang on, something is happening, but that protection of the whistleblower. But I think for us as a panel, we recognize that the most important thing to protect, if you had to choose one thing, is to protect the institution against corruption.
Great. Any further comments from panelists? There's a question or comment at the back. Yeah, right at the back. And then we will summarize and round up so that we are on time for the next session.
Thank you. I'm Nonhlanhla Malo. I'm from the Center for Health Policy at the University of the Witwatersrand at the School of Public Health. I actually wanted to touch on the issue of software, especially in relation to accountability, and also perhaps on the practicalities. And that sometimes we have processes, mechanisms, and structures that already exist that we could maximize on or optimize. For instance, at the facility level, the PMDS is often a hostile process, especially for facility managers. And at the moment, it's a very horizontal, formal, autocratic process, a top-down process where it could be relational, where people are accountability across the system. So facility managers are accountable to, the people that they report to. So those one of those things that we could inculcate as an institutional culture. And another aspect that I wanted to touch on is on participation, particularly community participation, and how I think it's still not prioritized, and I think it's neglected. And there are structures that exist, and I don't know if this was reflected on, for instance, clinic committees and community health workers, which still need a lot of investment. And those could be the leverage to stimulate community participation. They could be active in IDPs. They could advocate for more community participation. And I think we don't maximize on those mechanisms. Yeah.
Great. Thanks very much. Right. One comment, and then we'll go to Profayo Yusuf, and then I'll summarize.
Thank you very much. Dr. Camille Castellane from the Albert Lutuli Leadership Platform for Health, and it links to all the other comments from the floor as well, except that where recommendation number 4 about good leadership and ethical governance, we really need to look at local and indigenous knowledge and the way that we foster that, because we cannot use westernized concepts and concepts that the problem cannot be solved on the same level that it was created. So thank you for that.
Great, good point. I hope we had a little bit more time to dig into, what those would be, but maybe that's for another time and another session. Lakan? Profayo Yusuf? You're giving up. I hope I didn't intimidate you into giving up your, because I know you're not intimidatable. So let's conclude the session by just recapping a few things. So I think there's agreement by the panelists, by this audience, that the basic assumptions, the findings of the report, the recommendations in the report are spot on. There's been no discussion that there are things in the report that don't ring true. Anela says 80% ring true. We didn't have time to ask him which, the 20%, where the 20% lies.
80%, I'm aware of it.
Okay, he's personally aware of 80%, right? So we have endorsement that at least from this audience and this panel, that the report has a substantial level of verification. Secondly, we are at a pivotal point where we're going to have a new minister, hopefully by Sunday, and I think it's incumbent on all of us to step up, because the report and the report writers ask, if not ask who, if not now, when. So the time is now, and the people are each of us. So, and we should move from talking about these challenges. And I must say, being in the health sector for as long as I've been, we've been talking about these forever. There is very little, unfortunately, in the report that's particularly new. And that's what troubles me the most. And I think troubles all of us. And the question is, in the reset, what exactly are we going to be committing to? And how are we going to make it happen? Right? And I think we need to individually and collectively commit not only to the reset, but to ensuring that the health system delivers to every individual in our country. And I think that's a commitment we can leave here with. And again, thank you very much, firstly, for inviting me to moderate the session. Thanks to my fabulous panelists. Thanks to the panel who wrote the report. And of course, mostly thanks to ASSAf for commissioning this report. Thank you very much.
Thank you very much for those discussions and comments and participation, and to Dr. Pillay for really so professionally and so interrogating the issues that we are facing going ahead. So now we can put on our celebratory caps for a change. I must say, during these discussions, there was a point that I actually felt quite disheartened and sad. But I think the only thing that kept me going is that in the report and in your comments as well, that there's still hope. and that there are specific recommendations which can be taken forward that will add to much more positivity around sort of the negative and the daunting discussions taking place. I would like to invite the whole panel, as well as our interim vice president, as she calls herself, to the fore. And of course, Dr. Pulane, please could you join us here in the front, where we now officially will actually launch this report into the public space, which is very important and significant for us as well. So as we will launch sort of demonstratively, the report will be set out into the public space for all to see and sundry to interrogate and to give comments. So I think that's quite significant for the work that you've done and the celebratory feelings around that. So please can I invite you to the front so that we can witness then the launch of this report. I would like to ask the chair of the panel then to assist to unveil the plaque there that's covered there under the under the cloth. Please come to the fore and stand right there. Yeah. Can you just give us a moment just to get all the cameras ready, because this is very important. Are all the cameras set for this very important moment? Henriette, are you ready? Right, you're welcome to remove the cloth. Kindly may I request Professor Dudley to officially hand over the report to our Vice President to accept on ASSAf's behalf. May I also request perhaps the panel to very briefly just state their names for the audience, because I'm quite sure this is the first time you're actually surfacing here. Well, some of you at least here in the front, and people might be wondering then who you are. Can we just get a microphone for the... Oh, yes. Okay, thank you. We do for the people that's online.
Hi, my name is Gwen Lawrence, and I'm a National Nursing Manager in the private sector.
Thank you.
Good day. I'm Kuto Palani, and I'm a Program Officer responsible for health and related sciences at the Academy of Science of South Africa.
Hi, I'm Catherine Matthews from the South African Medical Research Council.
Hi, I'm Flavia Senkubuge. I'm the Acting Deputy Vice Chancellor of the University of Pretoria and Public Health Physician.
I'm Leslie London, a Public Health Medicine Specialist at UCT and participant in the People's Health Movement.
I'm Lillian Dudley, we've met. I'm a Public Health Medicine Specialist affiliated with Stellenbosch University.
Please, my request, those online, I know there's one or two panel members, please switch on your cameras and introduce yourself.
No, Mark.
Hi, Mark Blitzer from National Treasury, South Africa. Thank you all.
Good afternoon, everyone. Sharon von, Wits School of Public Health, and currently visiting the University of Gothenburg in Sweden.
I think that is the whole lot. So thank you very much. And to the panel, congratulations once again for this incredible achievement and contributing then to better the management of health systems in South Africa. So thank you very much. So just in closing, I think there's one very big takeaway message, I think for ASSAf as a whole, and for you as participatory participants to this meeting this morning, and that is a call to action. And I hope that ASSAf, with this report, can set the tone, at least the leadership, to bring all the parties together to take this report together. So, yeah, the pressure is big. So I would just like to thank all of you for availing yourself to attend this meeting. I hope that you have found it interesting and illuminating in terms of the problems and the solutions and the recommendations that have been put forward. So thank you very much for your time. Once again, thank you to our panel and then also to our project officer. And then very last but not least, at least to thank all the other ASSAf staff within the Secretariat who in the background also helps and run around and organize the things. And then a special thank you to our interim Vice President of the ASSAf Council for also availing you this morning. Just want to mention that lunch will be served down in the foyer, but there's an exhibition hall. It's a huge hall with many tables with black tablecloths. Please, would you join us for lunch there? I wish you well, safe travels, and any questions, I'm quite sure our panel will avail themselves to have a good chat and to discuss the report as such. Thank you very much. Have a good afternoon.